The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Welcome to Lymphcast, the gathering place for physicians, healthcare experts, and special guests. We dive into the world of lymphedema, venous disease, and other related disorders, exploring their impact on your daily life. So settle in, unwind, and join us as we uncover everything you need to know about lymphedema and related conditions on our engaging show Lymphcast.
Today's Lymphcast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Well, greetings and welcome to our Lymphcast show, episode 33 tonight. Glad you're with us. Whether you watch us on YouTube, a variety of different podcast platforms, we are glad you're with us. We're on Apple Podcasts, Spotify, Google Podcasts, Castro, and of course, as I mentioned, YouTube. If you'd like to see what we look like, you can follow along that way too. We also want to invite you to visit our website, lymphcastnetwork.com. All information on the show is there for you. And we want your questions. Send your questions in for the panel. The email address is hello@lymphcastnetwork.com. That's hello@lymphcastnetwork.com. Well, let's go ahead and meet our panel, and we'll get the ball rolling here. From California, Dr. Emily Iker. Hello, Dr. Iker. How are you today?
Hey, good afternoon, everybody. Thank you, Paul. And we are so honored to have our prominent physician and surgeon, Dr. David Amron, at today's podcast.
He will be with us, yes, in just a moment. We'll bring him in. And also the founder of this show. He's also the founder of VitaSupport MD. They make Vein Formula 1000, Lymphatic Formula 1000, and they are sponsoring tonight's show. Physician surgeon, Dr. John A. Chuback. Hello, Dr. Chuback. How are you?
Hi, Paul. I'm doing well. Thanks so much. Good seeing you again.
You too. We are ready to roll. And I'm not clear who is bringing in Dr. Amron. If one of the two of you want to take the honors, we will get going.
We could fight over it, but I'm going to give Emily that honor because she knows Dr. Amron personally very well.
We have the honor of presenting Dr. David Amron, who is an international leader in lipedema, liposculpture, revision of lymphatic surgery, and the specialist lecturer's mentor for many, many years. And I have the honor to know Dr. Amron personally for quite a few years, maybe close to 2 decades. But
yeah, thank you so much, Emily. I really appreciate that. We've known each other for years, and I go on her fabulous walks for lymphedema every year. So I'm looking forward to the next one.
And well, this year, unfortunately, it was canceled or postponed for next year. So we'll repeat that next year. But tell us about you. How did you start? You are a dermatological surgeon focusing very much on lipedema patients and improvement of their quality of life, reducing pain, reducing the volume of lipedema. What got you interested in that field?
Yeah, so I get asked that a lot. So I've been in practice 29 years now, out of residency and fellowship. And when I began practice in 1995, I said 25 years, 28 years. I began to focus my whole practice on liposuction surgery. So I'm a dermatologic surgeon. And what that means, I'm a dermatologist who's more surgically focused, doing skin cancer surgery in the past. And we developed a technique back in 1985, Jeff Klein, called tumescent liposuction. So it was in our area of specialization. And when I began practice, and I've told the story, I was having lunch with an orthopedic surgeon across the street at Sherman Oaks Hospital. And he said, David, let me tell you something. He goes, pick one procedure and try to be the best at it. And it kind of stuck in my mind at that point. And I liked liposuction. I felt I had a good knack for it. And it was always something that was a challenge for me. And I decided to put my whole practice around liposuction surgery. And right away, I began to get referrals from surgeons, things they didn't want to do, a lot of revision cases, a lot of complicated areas. And I got a referral from a facial plastic surgeon, Walter Deschel, who's an Encino, for a staff member of his that had fat calves and ankles. And I was referred to this patient. This is, again, like 28 years ago. And nobody was doing calf and ankle liposuction back then. And I'm thinking, you're not taught how to do this. There's no literature on calf and ankle liposuction. And I literally just had to figure things out. And for a month before the patient's surgery, in my mind, I'm kind of playing with designing and engineering this whole procedure to do her calves and ankles. And surgery came along, and I had already designed exactly how I'm going to do it, the entire unit, where my access points are, and saying what I call the safe plane, and kind of all the reasons of why not to do it, like compartment syndrome or DVTs, never really made a lot of sense to me. So I went ahead and did her, got a great result with it. And I began to get referrals from all these complicated areas. And then years later, I was on one of the television shows, these makeover shows in Europe with Paul Nassif, my ex-partner. He was doing facial plastics. I was doing all the lipo, and I was highlighted doing a lot of calf and ankle liposuction on patients. It aired in Europe, and all these patients from Europe started coming over from England and France saying, Dr. Amron, I have a lipedema. I want you to do my legs and make them look beautiful. And I'm thinking, lipedema? I'd never really heard of this condition. And started realizing all these patients that I was doing really had lipedema for over 12 years before. And that's kind of what got me into it. So it was sort of a perfect marriage of my skill set and these patients finding their way to me.
That is quite fascinating that you started something that you were not really prepared for. And at that time, we didn't even have a proper diagnosis for lipedema.
That's right. I mean, at least in the US, we did. And I'm not sure where things were at that point in Europe. Then when I began to do a lot of this, I started then researching some of the background of this and came across these guys in Germany doing lipedema surgery. I'm saying, wow, that is so weird. I thought I was the only one kind of in the world doing these surgeries. And I realized there's this pocket of surgeons in Germany, Stutz and Robrick and Heck. And I'm saying, how did that come about? And then I began to research this. And I then was at one of the meetings. I think you were there, Emily, many years ago. And I met Robrick and Stutz. And Robrick kind of told me the whole story, how it came about. So, and I don't know if you know this story. There was a German surgeon in the 1990s who went and took Jeff Klein's course in tumescent liposuction and took it back to Germany. And Stutz and Robrick learned from him and then applied it towards lipedema. So I go, that makes sense. How that came about. So here it is. We have an American-defined disease, at the Mayo Clinic, right? 1940, it was just kind of ignored. American-defined way of doing it, and we kind of just lost the ball on it. And that's how that whole thing came about.
Fascinating. I'm going to break in just for a second for our listeners, because I like to give a little bit of sneak peek of the rest of the show so that people know what to expect on today's program and all the interesting things we're going to talk about. I'm going to touch on a few bullet points. I just want to mention that Dr. Amron is the director at the Roxbury Institute in Beverly Hills, California, and he's going to tell us more about the Roxbury Institute. We're also going to be discussing his new location, which he's opened in Salt Lake City, Utah, why he's done that expansion and what that means to the lipedema community. We're going to talk about research that Dr. Amron and his team is performing at the Roxbury Institute. So for lipedema sufferers who are listening, stay tuned, because these are all going to be extremely, extremely interesting subjects on today's program, including the release of Dr. Amron's new book, which is coming out in a few weeks, and his associate, Dr. Arya, who's going to be speaking at the Lipedema World Congress in Germany next month. So please stay with us for the rest of this program, because we're going to be touching on many, many interesting subjects for patients with lipedema, looking for hopefully some of the answers to their problems that they have possibly not been able to find before. So with that, Dr. Amron, can you tell us about the Roxbury Institute?
I began the Roxbury Institute in Beverly Hills in 2014. My old partner and I went our own ways with things, even though we're still close friends. And I came up with a concept of a center that was trying to be not your typical Beverly Hills type of practice. At least, what still goes on in Beverly Hills is most practices around cosmetic medicine have a certain flavor to them. And I was trying to be more structured and academic in what I was setting up. And it had different divisions and departments. And it has more and more just become dedicated and focused around lipedema. And I've gone much more deeply into lipedema care, not only diagnosis, of course, surgery, decongestive therapy, nutritional guidance for patients, and have structured a lot of protocols and processes over the years with the team that I have here, which is a dedicated team. And it's just come from years and years and years of figuring things out. I've talked about this, medicine and surgery is very intuitive and creative, and figuring out ways of doing things and protocols that we keep refining. So that's what the Roxbury Institute is. It's a center that is really primarily dedicated to lipedema. I head it. I have a younger surgeon, Dr. Vazurnia, who's done a type of fellowship with me for between 12 and 18 months, where I trained him in all my techniques of how to do this. We've expanded the program with nurse practitioners also. I've now opened up in Utah another center with Dr. David Smart, who's finishing up a fellowship with me also in terms of the surgeries. And I'm trying to do things the right way and not just do something in a way where I'm busy and filled up, thank God, with patients, but have the same high standards of care across the board with things, which is not always easy to do. It's very easy to just be busy as a doctor and surgeon, hire somebody else, but to try to set protocols and processes that are standardized is something that I'm committed to. So
that's a very noble aspiration. Certainly, I know that resonates a lot with Emily, because we've talked about this many times on the program, that Emily, when she started in this area of lymphedema and lipedema care many years ago, as you said, Emily, and as Dr. Amron is saying, you had to figure a lot of things out along the way. Isn't that so?
Absolutely. In my case, it was a little bit less or more challenging, because in my surgical residency, I developed lymphedema in my right leg, secondary to lymphoma that I had previously. And in the old days, nobody notified you, hey, you may end up with having a swollen leg. But the first thing was, well, you don't have a cancer anymore. So be lucky, be happy, and go about your life and wear compression stocking. Well, we are so honored that we have fantastic surgeons, and I have the privilege to see the patients before Dr. Amron sees surgical intervention. And then sometimes I see the patients even after, and I see the fabulous outcome on most of the cases. Just like I tell my patients that I can deliver so much, and maybe 50% of your success improvement, but the other 50% is really up to you. And that includes diet, therapeutic exercises, wearing compression stocking, taking good care of your skin. Skin care is important, and daily attention to your problem. And what's so unique about Dr. Amron is that he is tailoring his surgical intervention for each patient on individual basis.
Let me ask a question, if I may. My background, of course, is general surgery and then cardiovascular surgery, having done open heart for a number of years and then transitioning over a number of years into strictly vein care. In my background, of course, as a surgical resident, and we've talked about this a number of times on the show, and it's something I'm really fascinated with, and I'm sure Dr. Amron can give us some insights. One of the things that we were particularly meticulous about and paranoid about to some degree was any kind of trauma, especially in post-breast cancer patients with lymphedema, post-axillary node dissection lymphedema, drawing blood, placing an IV, even taking a blood pressure. Now with lipedema, I guess I have a two-part question. One is, because I find this so fascinating, the work that you're doing. One is, what component of lymphedema, David, do you think lipedema actually possesses or manifests? And two, especially early on, if there is a component of lymphedema in lipedema, were you very concerned about making potentially the problem worse by intervening? And by the nature of liposuction techniques, possibly injuring additional lymphatics and possibly making the patient worse?
Those are really good questions. Let me begin by talking about my thoughts about how lipedema and lymphedema, relate to each other. And, Emily has a lot of knowledge about this, and she can, if I say anything that's not quite accurate, I want her to jump in with it. But the way I kind of view things is this. They're two separate conditions, lipedema and lymphedema. There are different types of lymphedema, though. Many times they can coexist. And let's get terminology down. There's obviously lipedema, lymphedema. There's something called lipolymphedema, which is lymphedema being caused by longstanding lymphedema being caused by longstanding lipedema, especially when there's a lot of fibrosis damaging the lymphatics. And then in certain patients, there is lipedema with some coexisting lymphedema. In those patients, in general, you will see an asymmetry from one leg to another. If there is long-term permanent damage to the lymphatics with long-standing lipedema, called lipolymphedema, many times that is a permanent thing. Liposuction, I find, can improve that by decongesting the fibrosis and to some degree improving lymphatic flow. And kind of the same thing with coexisting lymphedema too, that by decongesting things, sometimes the lymphedema will begin to improve also, but that's more variable because there's other causes of lymphedema. Generally, it's from the deeper lymphatic circulation. Is that right, Emily? Do you right. Kind of like
my question
agree with that?
When you go and do the aspiration, do you go superficial to superficial fascia, or do you go deeper?
Well, you're going superficial. I mean, you're not in the deeper. You've got the connective tissue fascia underneath you that you can't really bust through with things. So it's taking place in a superficial plane with it. But to answer the second question, was I concerned about things? I've always been careful when I do things. I think that what helped is by the time that I actually heard of the term lipedema, I had done so many liposuctions for years on these patients, not knowing I'm really treating a disease with it,
right, exactly.
without ever having a problem or causing lymphedema. And then I began to I remember I think it was Feldy, that she was sitting in front of me in one of the conferences in New York. And we talked a little about things. And she said something that I still struggle with today, that it's the superficial lymphatics that are important, that can get damaged, that can cause lymphedema in patients. And it never quite made sense to me because it has to do with technique of what I'm doing right now. I talk about these different planes that we're working in with things. And the subcutaneous plane I'm working with liposuction, what I call the safe plane, you shouldn't do anything that's going to be causing long-term, long-standing lymphedema in these patients. Or you have to be so egregious with your trauma to the superficial lymphatics to damage those. But that would never really occur because you would expect every patient that is doing liposuction, especially things like high-def lipo, to potentially be ending up with lymphedema with it. So I kind of go back to my thoughts that isn't lymphedema being caused by getting out of that safe plane and damaging the deeper lymphatic branches and trunks. And that kind of is the answer to the question. I still function with that mentality. As long as a surgeon is staying within what I call that safe plane, they really shouldn't be causing lymphedema from liposuction. If you get out of the safe plane, you go into the deeper lymphatic branches and trunks, you potentially can damage those and cause lymphedema.
It's a very interesting subject. That began doing venous surgery and venous interventions more than 15 years ago. One of the things I was really concerned about was the patients who you talk about lipolymphedema. We, of course, see a lot of phlebolymphodema. And I was really concerned about doing ablations on patients with phlebolymphodema because they had all of the telltale signs of lymphedema. And we had been trained as general surgical residents, especially, don't even put an IV in a hand vein in a patient who's got lymphedema because the arm may double, triple, or quadruple in size. So we were so fearful of that. And then little by little over the years, I've said this before on the program, in patients who initially were ulcerated. And I felt I had no choice. They were C6 disease patients who had venous stasis ulceration in the face of phlebial lymphedema. I felt that the risk-reward benefit was there, and I ablated those patients. And lo and behold, touch wood, over all these years, they've only gotten better. It was really quite stress-provoking initially because I was saying, oh my goodness, I hope I don't, try to help this patient, and suddenly they wind up with a gigantic limb. But some of this, I think, is still a bit of a mystery to all of us. I speak for myself. Maybe it's not a mystery, but the lymphatic system and how it relates to some of these other disease processes, and why the patients seem to react so well to these different interventions, like the ones Dr. Amron is doing, and the ones I'm doing in the venous system. I'm pleasantly surprised how well it works for patients, but there was a generation before us, I think, that would have said that doing these things was heresy. I mean, that you could really hurt somebody.
Yeah, I agree. So Emily, I'm curious. So, what I talked about with regard to my view of the safe plane and potential damage to lymphatics and how that all plays into it, what are your thoughts about it? Do you agree with that?
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
Well, I totally agree with you. There are a few surgeons that I spoke with, and they said they go to a deeper layer, but we know each other for many years, and I have been treating patients after the surgical interventions of your type of surgery, and it's truly amazing that I have not seen complications. Or just a week ago, 2 weeks ago, we had this wonderful patient that you operated on, and after liposuction, 3 days later, she drove herself back to Bakersfield. I mean, this is totally amazing.
Well, thank you. I mean, I do virtually always. The recovery is so clean the way in which I go about doing it by, again, staying in that safe plane, the proper preparation of the tissue, tumescent completely, not traumatizing things that shouldn't be traumatized, and which, I've talked about can happen more under general anesthesia, because you literally can do open heart surgery under general anesthesia, but it kind of forces you to stay in that safe plane. But I've begun also to realize that, we talked about, there's a whole other discussion about the different types of fibrosis of lipedema and how that plays into it. And as we all know, the understanding, it's not just about removal of the fat, it's how the fibrosis is dealt with and properly released and decongested. That's a huge part of the improvement in these patients. Quickly, I've seen there's 4 types of fibrosis: nodular, dense, and those patients I've talked about, I think, are the ones that are really at risk of lipolymphedema, that dense type of fibrosis. Strandy, and those people are the so-called swellers, where they got this network of fibrosis. And then the granular fibrosis that generally will cling to the dermis underneath the skin. And unless you release that completely, you're not going to get proper flow of the lymphatic capillaries under the skin with things. And, all this stuff enters into it.
When you talk,
go ahead.
I was just going to say, when you talk about the nodular, do you include people with Derkham's in that category, or do you treat Derkham's patients?
I don't include it in that category. I think Derkham's is a separate disease entity. I think it coexists with lipedema sometimes, but I'm not really including Derkham's in that, because Derkham's are supposedly fibromas that are inflamed and that. In these patients, I do treat Derkham's. I mean, I think maybe Emily referred me 1 or 2 patients with Derkham's, and it's a little bit more variable with Derkham's. I've probably done about 20 patients with true Derkham's with liposuction. And in the vast majority of patients, they get improvement. It's not as impressive as lipedema, but usually it's improved. I had one patient that became a little bit worse with pain after the liposuction. And my thoughts on that is, when you're removing a lot of the insulation around the Derkham's nodules, potentially you're kind of uncovering some sensitivity in certain patients with it. Mm-hmm. So Derkham's is less consistently improved with liposuction.
Interesting. Has that been your observation as well, Emily?
A few patients, I have about 20 30 Dercum's patients, and the few that went through the liposuction improved very nicely. The quality of pain was reduced. But one thing I want to point out, when I do the ultrasound, I usually see the coexistence of lipedema and Dercum's. I have not seen just plain Dercum's without lipedema.
That's very interesting. That's so, it may be, it may never really exist without lipedema too.
But I see that on the ultrasound. And many times the patients are coming and I say, I have a specific pain and very excruciating pain. And when I go with ultrasound probe, there it is. It looks like a little snowball. And I just presented in Geneva, there are 4 types of Dercum's, but I found that there is more than that. I found the Dercum's now in muscle tissue. And I had several patients who came and they were complaining of pain on sitting. And of course, the last patient was sent to see I was the 9th doctor that she saw. She was sent by the doctor number 8 to see a psychiatrist because it's supposedly all in her head. And it was heartbreaking for me to deliver this speech when a wonderful lady, and I don't know, I think she was somewhere from Asia. During my presentation, she started to cry. And she said, now I understand I have Dercum's and nobody believed me. And this is the problem with the Dercum's. If you don't have ultrasound and you don't scan this, you may not see that they have Dercum's disease. And back to the patient, she had Dercum's in a gluteal muscle, embedded in a gluteal muscle. And I think with that, surgical intervention would be very challenging. However, now we have the MPFF formula, which may reduce the sizing and inflammatory process of the Dercum's as well as in lipedema. So Dercum's is completely different entity. However, from my background, when I do the ultrasound on pretty much all the consultations, I detected Dercum's in coexistence with lipedema.
Interesting.
In most of the Dercum patients I've seen, there tends to be more of involvement truncally of the Dercum's. Is that your experience too, Emily, that most patients with Dercum's will tend to have involvement in their torso area?
Not necessarily. I've seen Dercum's just about everywhere, not only trunk. This particular patient that I was talking about, she had it pretty much just in gluteal area and lower body.
What I meant by that is that, it will be everywhere. But whereas with lipedema, typically you're not going to get primary involvement in the upper part of the torso. You will in some patients. With Dercum's, it commonly is involved in the torso area.
Yeah, that's correct. And it's interestingly that in Geneva at the World Congress of Lymphology, the German group is still visualizing lipedema as obesity. I am so happy that you will go to the meeting in Potsdam because I want to hear what you learned there and what was discussed, because after going from one Congress immediately to another in Miami, I don't think that I have the strength to go back to Europe.
Emily was pretty wiped out. I can attest to that. She was traveling a lot.
You're not going to Germany, right?
No, not this time.
No, but Linda Ann Kahn and Karen Herbst will be there.
Yes, she is. Yeah. You are going, right?
Yes, I'm going. Yes, me and Dr. Versernia. Yeah.
Excellent.
We saw them both in Miami, Linda and
Karen Herbst.
Karen were both. Yes. David, I have another question for you, just out of curiosity. I had a plastic surgeon, very dear friend of mine, that we trained together in general surgery and so forth. He was with me about 7-8 years. And like you, we went our separate ways, but remained very, very dear friends. He was doing not liposuction for lipedema, but just cosmetic liposuction, laser liposuction here in the office under tumescent anesthetic. And he was new to it. And I had been using tumescent anesthetic for many years, doing endovenous laser ablations, et cetera, and microphlebectomies and so forth. And one of the things that I convinced him to do that he liked very much, and I wonder if you're doing that, because we're talking about ultrasound, was to use ultrasound for ultrasound guidance of the tumescent anesthesia for the liposuction cases. And he could be very specific with it in terms of the levels and so forth. And I was thinking of it when you mentioned the levels of your liposuction and so forth. So I wonder if you have any experience with that.
I don't. You
might want to try it. You might want to play with it. It's very, very
well. It's so funny with Dr. Verzerny, when I trained him the whole, technique, the first thing was learning to tumesce completely and properly and the skill of being able to do that. And it begins to be such a tactile thing. It's almost, you can almost close your eyes and you can feel exactly where you are with things. And so I tumesce really efficiently. I just have my whole process of tumessing. I think if I added more technology to it, it'd probably just reduce the efficiency.
For you, I'm sure that you've been doing it so long, you're obviously tremendous with it. But perhaps if you want to train other people, because
that's probably a good thing. Yeah.
Yeah. When I think about how many, let's say, central lines I put in as a general surgeon and cardiac surgeon, blindly based on anatomical landmarks and so forth, and being very proficient and excellent. And then when I started using ultrasound guidance for line placement and so forth later in my career, when I got into the veins, because I was still doing cardiac, and I started putting in swans and this and that and femoral lines, all with ultrasound guidance, it was amazing. It was like an eye-opener that as great as we were doing before, this extra technology really opened a whole new world. So I'm just thinking about it for you. If you're going to be training more young surgeons, it'll take a long time to get David Amron's kind of touch and feel and tactile feedback and the sense. But it's something to think about looking at.
I think that's actually for training. I think it's a good idea. I've seen even Dr. Verzerny, how he's gotten so skilled after a while with it, but I think it would actually probably speed up that training process of things.
I'm really surprised what you can see in terms of the different levels and how precise it can be.
Yeah.
So it's an interesting thing. I thought I would ask.
Yeah, Emily, I don't think, you were talking about Derkums in the muscle layer and stuff like that. Do you remember Karen presented at, where were we last? It was Atlanta, right? For FDRS? Atlanta, right?
I think so, yes.
Atlanta, yeah. Lipedema fasciitis.
Yeah, absolutely.
How interesting that was. I mean, we know they're all systemic diseases, lipedema and Derkums also, but she presented some really, really interesting stuff about lipedema, the process being under the fascia.
Right.
And again, not surprising.
I hope that you are going to meet the authority and about fascia. Definitely, we need to start exploring where the pain does come from. Does it come from fascia or something else or so? But going back to Genoa, regarding ultrasound, the Japanese group came up with the fantastic high-powered, high-frequency ultrasound. My ultrasound has probe of 15 megahertz, and they were showing ultrasound-guided surgeries, and this is for lymph to vein anastomosis, lymph node transfer, and so on, of 70 megahertz. And wow, what a difference you can see when in a 70 megahertz ultrasound, you can visualize the lymph channel and lymph node. And so the technology is evolving. It's amazing to see how crisp those slides are, and the plane is so beautifully visualized that you know where you are at and what surgical approach you can take from that point on. But again, this is not so much for liposuction. This is for lymph to vein anastomosis and lymph node transfer.
A good tool for research, even in liposuction. We've talked about that, Emily, combining our efforts for research on these patients. And I think that, I want to talk to you more about that.
Let me ask another question. This is for our listeners, I think, very important. Dr. Amron, what do you see in terms of the need for and the future more physicians being able to make the diagnosis of lipedema, and also the training of more surgeons like yourself, because it seems so many of these people are suffering and without ever being properly diagnosed?
I mean, huge important area, and awareness is increasing a lot slower than I would have hoped for 10 years ago. I kind of feel over the last year or two, there's been a big uptake. Maybe it's social media and influencers and this and that. But yeah, more physicians need to know about it to be able to diagnose it. I kind of talk about one of the reasons that they don't is because we never learned how to medical school, right? I think it was kind of given a little bit of a weak name, lipedema. It was confused with lymphedema, never made it into our medical school Rolodex of diseases. And so to now get physicians to learn about it, it's important. And again, Emily and I talked about this. I mean, besides speaking in our core areas, which we do at these conferences, I think it's very important to get out and speak to larger groups of other types of physicians. I mean, not only just, vein surgeons, but pediatricians, OBGYNs, internal medicine doctors. They need to be learning about it and be able to diagnose it. It's still crazy that patients, in many states can't find a doctor in their city to even just diagnose lipedema. So that's hugely important. I think it needs to be taught in medical schools. Until it's consistently taught in medical schools, doctors are going to still move on their careers with the ignorance of not knowing about lipedema. Emily, you want to add to that?
Just think of the AVLS. Only recently, they included lymphatic diseases into their program. I remember 20-something years ago when I gave first talk about the American Medical College of Phlebology. I was so taken when most of the vascular surgeons were just leaving the lecture. And I thought, wow, I prepared myself so well for it, but they were not interested in lymphedema. And now it's complete opposite. Now, when you go to these meetings, anything about lymphatic or lymphedema, lipedema, there are so many vascular surgeons almost hungry to learn because now they have the proper diagnosis and now they have patients. And with social media, there are so many lipedema groups and so on. And the best is, of course, word of mouth. And then they are bringing everything out to the attention. So these women are, yes, they are suffering, but they are not quiet and they are not hiding at home. They are seeking a potential treatment, if not cure.
Yeah. Probably 90% of the consultations I do on patients, which virtual or in person, the first question I ask them is, how did you hear about lipedema? And unfortunately, 90% of them, they basically self-diagnose themselves. They've come across the term somewhere on social media, whatever it is, and that needs to change. I've said that we screen for diseases that are far less frequent than lipedema in children. I mean, shouldn't we be screening for lipedema? Shouldn't pediatricians or OBGYNs be screening for it at puberty? I mean, yes, it's not that difficult. The characteristic symptoms and signs and family history, and bingo, it's most likely lipedema. It's not that complicated to diagnose.
Let me stop you right there, please. I hate to interrupt, but for our listeners who may be wondering, do they have this disease? Does their daughter have this disease, et cetera? Share with them some of those characteristic telltale signs that might send them, and also share with our physicians, primary care physicians and so forth who may be listening. What are the, pathognomonic signs, classic signs people should be looking for?
I'll kind of run through them and Emily can chime in, but I'm going to hit on the main points. So it's based primarily on signs, symptoms, and then, to me, family history, helps confirm things. But you'll see typical signs of lipedema, and it will typically begin presenting around puberty, but a lot of times even pre-pubertal. I mean, Emily said this also. A lot of times you'll see lateral malleolar swelling in younger children as one of the first signs of lipedema. Generally around puberty in girls, they're going to start seeing some of the subtle changes with things, the subtle loss of contour to the legs. You've got different patterns of lipedema, either the column pattern type 3 or the triangular pattern type 2. But you'll see swelling as one of the first signs where you start to lose the definition of the shape of the legs. Generally, the legs will present first, the arms not till years or decades later. Some patients will begin to have a little fullness in the upper buttock area, those type 2 patients. So you're going to see changes in terms of patterns of distribution that are characteristic. Along with that, you'll start seeing some of the symptoms of lipedema. Generally, swelling is one of the first symptoms you'll begin to see with lipedema. Then you'll begin to possibly have some of the characteristic sensitivity to tenderness, achiness, heaviness, pain in patients. Sometimes that won't present until, years later, though. Easy bruisability is another common symptom in most patients with lipedema. Most patients, about 85%, have variations of Ehlers-Danlos syndrome with hyperflexible joints. I think a lot of these patients have a disproportionate number that go into gymnastics or yoga or cheerleading because they can do splits and stuff like that, or ballet. It's just not by coincidence. So they're hyper flexible, most of these patients. They tend to have a little more of a pliable quality to their skin, even at a younger age, again, because the skin, a connective tissue, is affected in lipedema. I think they're eventually going to find that lipedema is primarily a connective tissue disorder. It's a whole other discussion with a lack of integrity of connective tissue, and the fat is a secondary phenomenon going on. And then, for me, I'm pretty convinced that's an autosomal dominant inheritance pattern with variable expressivity. So you'll generally find almost always picking up the gene from either the mother's side or the females on the father's side of the family, his sister, his mother, his grandmother. Men will carry the gene as frequently as women, but rarely express the gene. So again, characteristic signs, symptoms, and generally, you'll dig around for some family history to confirm it.
I think, thank you. It was a wonderful explanation. My Bianca has lipedema, and I detected it when she was about 3 years old.
Yeah,
I am
told me
blessed
that.
that I have twins. And when I touched Marco's upper arm, it's a little tree trunk. And when you touch Bianca, it's nice and soft and fluffy tissue consistency. And this is the connective tissue problem. It's very loose. And along with that, all the other symptoms are coming. And yes, there was hypermobility, early hypermobility. And then it really blossoms with the onset of first menses. And then it progresses if not treated. And so I think our little children have to be evaluated even before they are age 10, 12, and so on. And you pointed out from time to time, I watch the gymnastics. And when I see the hypermobility and a little bit of fullness in the thigh, I go, bingo, here we go. And then from time to time, you can see the mother attending the little gymnast, and is, of course, it's right there. And so with my patients, what I always ask, do you have any girls? And bring them here, and I'll do the ultrasound to confirm the diagnosis. So then the mother and daughter can do sport activity together. And then the nutrition is changing the approach of the IBS and all the GI problems, which is part of this lipedema deal. So they can do it together. And one thing right before my conference is Bianca came up with the idea that she is now working on a website for lipedema in children.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation. And at VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
Because she is going to be 16 and she feels that these children should be aware what the signs and symptoms are so they can start addressing it. But I did with the ultrasound study on Bianca in 3 months of cross-country running, because she's on a team in the high school, we reduced the subcutaneous space by 35%, which is enormous. So yes, you can improve, and you can improve nicely when you address this very early. It's difficult when someone is stage 3. You cannot walk, you cannot run, you cannot, and the diet, even though you address the dietary component, it's not going to be as efficacious if you address it globally with other issues.
It's so true. But, also it really begins to affect people's emotions. And a lot of young girls who are seeing a change in their body are starting to develop eating disorders. They're many times shamed and blamed and misdiagnosed as just, being overweight. They go down the rabbit hole of various different weight loss therapies, usually to no avail. About a third of the patients I consult with have already done bypass surgery because they were incorrectly diagnosed as simply being obese based on archaic BMI indexes. And that's something we could probably talk about also. I've been on a warpath to get people to look at BMI as really an archaic way of judging people's bodies, because with lipedema patients, they have higher BMI indexes, but they're so disproportionate. And they're many times misdiagnosed by weight loss surgeons. They get weight loss surgery, they'll lose a chunk of weight, of course, and their lipedema just hasn't really changed at all because, again, the diagnosis was missed on these patients. So it really, I hate to say, messes up their life, and it goes on for decades. The average age I see patients for probably somewhere between 45 and 50, many patients in their 60s, and they've suffered with things. And here it is. They're self-diagnosing themselves based on things on social media. I mean, this has to change. I certainly think we need more surgeons treating lipedema. I think it has to be done the right way, with the right heart and soul and dedication to these patients. Lipedema surgery it's a very different type of surgery. These are different types of patients. There's a lot of important pre-care and post-care. Ideally, a surgeon should really dedicate their practice, not just what I call dabble in lipedema surgery. I think that they should not just look at it as another revenue stream and stuff like that, and add it to their list of things they offer. Because if you put yourself out there as a lipedema surgeon, you really need to be capable of dealing with every type of patient, not your just non-complicated stage 2 patient, but your stage 4 lipolymphedema patient, or even your stage 1 patient that might have their own certain things. So I do want to see that we're increasing the number of surgeons, but I think it has to be done in a careful way. Maybe it needs to go the direction of really an accredited fellowship program with things in lipedema surgery, because it's its own thing. I mean, I do this fellowship through my Roxbury Institute in my own way. It's almost an apprenticeship for a year where I train somebody specifically in it. But I think that going towards an accredited fellowship is a goal that we should have.
No, totally. I love that idea. I'm always for accredited training and formalized training and so forth. And Emily and I have spoken many times. We also feel we need a lymphology residency or fellowship in the United States. And I think a lipedema surgical fellowship, which would probably be a super specialized fellowship after somebody already has basic surgical training in liposuction and so forth, would be phenomenal. Because yes, I mean, we see it in the vein world everywhere, where people who are just inadequately trained go out and buy themselves a laser and an ultrasound machine and set up shop. And the butchery that we see going on is really, really inexcusable in a country like the United States. And now I'm beginning, and I'm sure you're sensitive to that, I'm beginning to see this same trend happening with people jumping on the lipedema surgery bandwagon. And it's dangerous. It's a very dangerous
Karen Herb said this about 10 years ago that, she's concerned about with lipedema surgeons expanding in terms of not proper training. But back then, there were very few people doing it. So where are they going to learn from? Where's the accreditation board? We're at a point now with things that it has expanded. And I think that it's needed. And the same thing with vein therapy, too, and vein surgeons. I think you're right. Anybody can buy equipment and get into it without the right type of training.
The problem is that we're going to have to come to some solution about eventually as a profession, is that there are wonderful things about office-based surgery, but when the office becomes unregulated Wild West for unscrupulous physicians who are simply looking to make money, then it can be very dangerous. That's why the old hospital system worked very well in the sense of credentialing, proper training, mentoring.
Yeah.
So on.
The irony is that sometimes innovations happen outside the hospital academic system. I mean, with almost everything. And I think lipedema is a good example of that. It's like people like me that have pioneered therapy for this, and the academic institutions which are referring me patients because they don't have it together with it, have kind of lagged behind. Maybe it's because of bureaucracy. I don't know exactly. So it's kind of a balance of those things.
I agree. And sometimes what happens is pioneers like yourselves, then eventually the training segues back into the academic center, because there has to be not only formalization of the training and standardization, which you're working on at Roxbury so beautifully, but also it has to be rolled out in a quantity and in a level that can serve a country the size of the United States. So one good surgeon like yourself, training a few talented fellows over time, it's valuable, but it turns out to be a drop in the bucket. That eventually,
You're right.
All of these things that have been innovated by creative and talented people like yourselves, ultimately it has to trickle feedback into the academic milieu for formalized training so that it can be rolled out in a meaningful and large scale way so that everyone in every state, in every city can be properly cared for.
And I agree with that. That's why you early on mentioned research, and it's something that I have been. What word do I use? Too busy, I guess, to be tackling. And now that I have these younger academic superstars with me, we're determined to significantly contribute to the literature for lipedema and to be churning out studies and stuff like that. So we're literally going to start journal clubs once a month at the Roxbury. About this and start really getting serious about research. Dr. Vazirny is going to speak at the World Congress on GLP-1 agonists and lipedema, but we're just starting all these different projects, which is exciting.
I'm sure you're going to make a huge impact. We're going to segue to Lighthouse segment, where we're going to take a question that one of our viewers has sent in, and then we're going to wrap it up. An hour goes very quickly, folks. This is a great discussion. Paul, do you have something for us?
I sure do. We want to remind our listeners and viewers, if you have a question, send it in and the panel will tackle it for you. And that email address is hello@lymphcastnetwork.com. Again, hello@lymphcastnetwork.com. Send your questions in and the panel will take care of them for you. Okay, tonight's question, Dr. Chuback, and anybody can take this on, or all three of you, however you want to divvy it up. How does lymphedema affect sleep patterns, and what can I do to improve sleep quality?
I think that's a great one for Dr. Iker.
Very good question. But now we know that lymphedema, you have an inflammatory process going on in your body. It's not only in your limb, in your leg or arm, wherever the lymphedema is, it is throughout the entire body. Now, imagine your body is filled not only with the toxins, that it's not being filtered properly, but now you have inflammation on the top of that. Of course, you are not going to sleep well. So we advertising healthy diet, according to Lymphedema Lipedema Nutrition Guide. We are now having lymphatic formula with micronized purified fractional flavonoids, which are supplements. And a function of that is not only to promote the better flow of the lymph, but also to reduce the inflammatory process. And of course, the diet is important and exercises. So with that, if you pay attention and focus on everything other than just being sedentary and not moving, then you definitely are going to have much better sleep.
Excellent answer.
Okay, would you like to
add, Dr. Amron?
I can't really, because I'm not as much of an expert in purely lymphedema as Emily. So I agree with what she said. It makes a lot of sense, but I
think it's
wish
really
I could
good
answer.
Information.
Yeah.
And I think, of course, hands-on MLD therapy for those patients will also help. If I don't know if she mentioned it, but of course, that's her area of great expertise. Do you want to do one more, Paul, perhaps?
Yes, absolutely. And this one is on the opposite end of the spectrum, a little more active now. Can I still participate in sports and other recreational activities if I have lymphedema? And what precautions, if any, should I take?
I just returned from Geneva, and patients asked me, how did your leg behave? Well, I say, I took my leg with me, but I do wear the compression stocking, and I do go for walks uphill, downhill. I do exercise, and I try to maintain my weight. Even a 1 pound or 2 pound plus affects my lymphedema in my leg. So I try to be very cautious how I eat and what I eat. And exercise is okay. Overdoing with exercising is not good. And you may damage your tendons, your joints, and so on. But start gradually. If you never exercise, start walking. Do very gradual exercise. And each time you feel better, add just a tiny bit more. Stay active. Don't just sit and be couch potato. And
when you're active, the muscles are squeezing on the lymphatics and helping to improve the flow.
Exactly. And in addition to that, they're also squeezing on the venous system, and then you get better venous outflow, and any component of phlebital lymphedema you might have should improve as well. And of course, your compression is also very important. And I know, Emily, one thing you didn't mention, I know you're also a great fan of swimming for these patients.
That's the best exercise for lipedema and lymphedema. You are doing breathing exercises. And again, I cannot emphasize enough the importance of breathing exercise, where you move the diaphragm, you speed up the lymph flow, and you see already the outcome when you practice this on a regular basis. Yeah. So swimming is the best exercise for both lymphatic disorders and lipedema.
And I think it's important to look at breathing, deep breathing, and so forth as an exercise. It's very, very well stated. Well, with that, I think we've unfortunately come to the end of our 1 hour very quickly. So, Paul, perhaps we'll go around and sign off.
All right. Another terrific show. You've been watching Lymphcast, episode 33 tonight. And again, send your questions in. hello@lymphcastnetwork.com. Check out our website. Everything is there, lymphcastnetwork.com. On the podcast platform, Apple Podcasts, Spotify, Google, Castro, just about everywhere. And, of course, on YouTube. Let's go around and thank our panel tonight. Dr. Iker, would you have the honors of thanking Dr. Amron for us, please?
Thank you so very much, Dr. Amron. This was fantastic presentation for all the lipedema patients, not only lipedema and lymphedema patients, and we are honored to have you on our podcast. Thank you.
Thank you so much, Emily. It's been great knowing you've been working with you for all these years.
And it's a pleasure to have met Dr. Amron today for the first time personally, of course, digitally, but personally, and congratulate you on all of the excellent work you're doing and pioneering work you're doing in the education, the training. And I encourage you to pursue your dreams of more research. I'm sure you're going to be very successful there. And I'm going to invite myself to visit Dr. Amron when I come to visit Dr. Iker. I want to see both of them in action. I have a lot
Absolutely.
To learn in this area. Not that I'm going to become a lipedema surgeon, but it's always so helpful when you can see something with your own eyes. It really sinks in a different way. And as I said, I have a lot to learn. So thank you so much for being our guest, and come back anytime.
Thank you so much, Dr. Chuback. Thank you. Paul, you sound great. I love listening to you.
I appreciate that, sir. Thank you very much. Great to have you, Dr. Amron. And like Dr. Chuback said, let's get you back on here one of these days.
Let's do it. Listen, I do want to talk about the how we work together in terms of vein therapy and lipedema surgery in these patients. It's a very, very big topic.
Great. We'll have you back for that talk.
Yeah, let's do it. Yeah,
all right.
Great.
Sounds good. We also want to thank from California, Dr. Emily Iker. Thank you, Dr. Iker, for everything tonight.
Thank you very much. I'm honored to be part of the family here.
All right. And the founder of this show, also the founder of VitaSupport MD. They make Vein Formula 1000, Lymphatic Formula 1000, and they sponsored tonight's show. VitaSupport MD did. But the founder of both, physician, surgeon from New Jersey, Dr. John A. Chuback. Thank you, Dr. Chuback, for everything.
Thanks, Paul, as always. Great show. Thank you, guys. Thank you.
All right. And again, it's been our Lymphcast show, episode 33. Thank you for tuning in. Join us in a couple of weeks for episode 34. Have a terrific evening.